Dr. Gite.
Sir, good evening.
Good evening. Gite sir, मैं आज different case scenarios है तो first case जरा discuss करते हैं and then all other cases we'll just give the short history and ask them which are the all investigations you want to know, show them all the investigations and directly on management and then other questions.
Okay, sir.
Because we have discussed couple of times, 3-4 times about PU junction obstruction. So we just want all different scenarios.
Yes, sir.
And so because in exam they may get different types of cases, so they should know how they may not get a classical case. Yeah.
Yes, sir.
So as soon as now Maheshwari has joined.
देख तो नहीं रहे.
हाँ.
I'm there, sir. Good evening, sir. Gite sir, Gaurang sir. Good evening.
Good evening, sir.
I saw you, but Maheshwari has not joined once because his input will be very important.
Yes, sir. Yes.
Okay, so we'll just wait for 2 or 3 minutes and then we start. Paras is just joining.
हुद्देदार सर भी ज्वाइन हो गए सर.
हाँ ठीक है, तो हुद्देदार सर को भी जरा co-host बना दो. We'll take input from him also.
Sir, तुमने जे करे છે?
Hi.
See, I'm joining urology class.
Yes.
Very good.
Very good.
So after Tanvi, you will be there. You will be helping us.
Hey, good evening, sir.
Good evening. Very good evening, beta.
Good, yeah. अच्छा, पारस ज्वाइन हो गया ना? Yeah. So let him share the screen. Paras.
पंकज सर को एक मैसेज कर देते.
हाँ, मैं फोन करता हूँ.
Okay.
Sir, answering person who is answering today, sir, so that I can make co-host.
Who is answering? Who is answering today?
Dr. Abhishek Ghosh from Jaslok Hospital.
So Ojas here, sir.
Ojas. Anyone today? Whoever is. I want another 2 fellow. If someone is willing, whoever has joined, third and fourth cases we can take them inside. So chat box may please, write down your name if you are interested in answering. There will, the questions will be very simple, so don't worry. After first case, we are just going to discuss how you are going to manage different cases. So only your input. So anyone wants to present, answer today, please write down your name in a chat box. टाइम मिले पे ज्वाइन कर दो. आज 3-4 फ्यू जंक्शन ऑब्स्ट्रक्शन है डिफरेंट. ओके ओके, महेश्वरी को मैं ऑलरेडी मैसेज दे दिया है.
जी सर.
So I think we should start now. He will join.
Okay.
Okay. Sure. Paras,
Yes, sir. Yes, sir.
this is Rajesh's, I think, phone which is making sound. Rajesh, mute yourself. Okay.
One minute, sir. I'm just not able to connect. Hello.
Yeah.
Hello. Yes.
So today 2 persons, Abhishek and Ojas is answering. Any other name in the chat box? Paras, if you come across any name, please let me know.
Yes. Sir.
Okay. Fine. Okay, Paras, you
Yes.
can start.
Yeah. So presenting the case of 1.5-year-old boy resident of Mumbai brought to the Safi hospital by his parents with chief complaints of left loin swelling since 3 months.
Yeah. So Ojas.
Yes, sir. Sir, regarding the swelling, first to ask when was the swelling? As I mentioned, it was noticed 3 months back. How was it noticed? Whether the swelling has increased in the size over the last over the 3 months, or whether it has remained same in size? Whether there is associated pain, any other symptoms of pain or fever? Any? Then I would like to go on to his history regarding birth history and before that. So any antenatal history regarding any imaging done which showed an abnormal. Normally, whether there were any episode during the first year of his life, whether any imaging was done, whether he had any history of any pain, any other imaging done, any history of decreased output, any history of any intervention done. First, I like to ask this, then like to proceed else.
Okay. Abhishek, will you like to just elaborate in just 2 minutes? And then
Yes,
we'll
sir.
go ahead.
Yes, sir. Sir, history, basically only that much I want to ask. With the specific history, or specific history of antenatal period, sir, whether the mother was diagnosed with any kind of oligohydramnios or not, whether she was mentioned this, any kind of intervention that happened, intervention that was took place. Other than that, sir, history of the pain, onset, duration, progress. Sir, whether the pain is associated with any, whether the swelling is associated with pain or not, whether there is any history of hematuria or not, hematuria, any lithuria, any hematuria, lithuria, any history of fever, recurrent UTIs, sir. Other than that, yes, sir, basically all rest of the other history has been asked, sir.
See, please understand this. He is a 1.5-year-old boy. Okay. So
Yes,
there are many history which he cannot give, or even the parents will not come to know. So you have to ask in a different way. You cannot ask about the pain. 1.5-year boy will not say that he is getting pain. He may not be talking also. So they
we'll
will,
ask.
it will be associated whether excessive crying, and not
Crying,
eating
nausea,
food,
vomiting,
withdrawal.
failure to thrive, decreased weight gain.
So okay, so the 1.5-year-old boy, how he will behave? If he has got a pain, he will not play. He will not be a joyful, not playful. He will be sitting in one corner, okay, or he will have excessive crying. So these are the things. Or while he is passing urine, whether he is crying. So these are the things you have to ask.
Yes, sir.
So Maheshwari ji, any input from your side? Gite sir.
Sorry, I've just joined. I will get involved.
Okay. So Gite sir, you want to give any input regarding,
Sir,
because they may
here
get such a small boy in the exam.
patient patient antenatal history is very important. If patient had a left-sided lump, so there should be 3 to 4 or 5 reasons which causes the lump in that age group. They should think about that and ask the history as per the whatever they are thinking. Like antenatal history is very important in this patient. Then in causes of antenatal causes which represent postnatally as a lump are PUJO obstruction near about in 40% cases, UVG obstruction probably in 20% cases, multicystic dysplastic kidney initially presented as a lump. So patient may have ureterocele, patient may have posturatal wall, patient may have ectopic ureter, then patient may have sacrococcygeal teratoma. So these are the causes which leads to the hydronephrosis and lump. So these are the obstructive causes for left-sided renal lump. And presentation again pain. Sometimes it is hematuria. He may not hematuria. Then he may not say UTI, but parents say he will pass while passing the urine. He is crying. He is pinching his prepuce while passing the urine. Then abdominal mass already he is presenting with any antenatal or immediate postnatal surgical history, any history of trauma, then any history of renal failure. So these are then if there were anyone is suspecting the PUJ obstruction, then associated congenital anomalies like vascular reflux in 10%, then cystic multicystic kidney disease. Sometimes esophageal atresia may not be presenting classically. Then congenital heart disease associated with, then imperforated anus. He may have undergone surgery for imperforated anus. These are some 3 to 4 other congenital anomalies associated with the PUJ obstruction. So in this patient, we have to think PUJ, then cystic disease of the kidney, maybe congenitally, and anything which causes the obstruction to that system. That may be PUJ obstruction, stricture, stone. Anything can be possible. So history should be inclusive of all the causes, so that the examiner should, after listening, examiner should feel he is thinking by broad way and not going by the way he knows the diagnosis.
Okay, fine. Paras, go ahead.
As per the history given by the patient's mother, patient was apparently asymptomatic 3 months back when he started developing a left loin swelling, insidious in onset, gradually progressive. It was first noticed by a local doctor when the patient went for regular immunization. Swelling was painless as there was no history of any persistent cry or crying during maturation or playing. There is no history of nausea, vomiting, fever, burning maturation, recurrent UTIs, no history of trauma, no history of similar complaint in past, no history of facial puffiness, lower limb edema, dyspnea while playing. Antenatal history, no abnormality was detected in the antenatal scans. Past history, no history of any comorbidities or surgeries. Family history, patient has one sibling without such abnormality. Developmental history, all milestones are achieved as per age. Immunization is complete as per age. Appetite is adequate, bladder bowel are regular, and sleep is undisturbed.
Abhishek, next.
Sir, next I'd like to examine the patient, sir. So on general examination, sir, vitals of the patient, sir, the abdomen of vitals of the patient, sir, any specifically any edema, sir, lower limb edema, I would want to see in that patient, sir. Other than that, on general examination, sir, milestones I would want to ascertain on general examination, sir, whether whether there is any kind of failure to thrive, sir. I would want to take the height and anthropometric measures of the patient, and sir, assess with the nomogram whether his developmental history is normal or not, sir. Other than that, yes, sir, I would proceed with the systemic examination and examine the lump per se, sir, in the abdomen, sir, inspection, palpation of the lump, sir. So that way I want to proceed, sir.
Ojas, you want to add anything? Otherwise, we'll go ahead.
So we will what? So, no, sir. The anthropometric general examination and then the local.
Okay, fine. Okay, then Paras, go ahead.
So in general examination, patient height, weight, and mid-arm circumference is appropriate for his age. Pulse rate is 130, respiratory rate is 20, afebrile, mass saturation is 98%. There is no ictus, pallor, clubbing, lymphadenopathy. Head to toe examination and spine examination is grossly normal. On per abdomen examination, inspection, large swelling located in the left side of the abdomen involving in the left lumbar, left iliac fossa, umbilical, and hypogastric regions, roughly around 15 into 10 centimeter in size, overt and shape, normal overlying skin with well-defined margin, no cuff impulse. Cuff impulse is negative. The swelling is non-pulsatile. There is no visible peristalsis. On palpation, there is no local rise of temperature or tenderness. There is a bimanually palpable large mass of 15 into 8 centimeter, smooth in surface, soft in consistency, compressible, non-transilluminate, non-pulsatile, not fixed to the overlying skin, non-reducible. The finger can be insinuated below the left subcostal margin. On the genital examination, penis is grossly normal, all hernial orifices are normal, scrotum is well formed, bilateral testes is normal on palpation. On percussion, there is dull note over the lump. Other systems are within normal limits.
Ojas,
Yes, sir.
you wanted to ask about the antenatal history.
Yes, sir.
So basically, what you want to know?
So in antenatal history, whether any antenatal scans or ultrasonography was done, in which there was any evidence of oligohydramnios for the mother, and for the baby, whether there is evidence of any hydronephrosis. Also, so this as in antenatal hydronephrosis and oligohydramnios, and whether any intervention and after birth, the initial period, and whether on follow-up imaging, what were the findings?
So Abhishek, what are the different things you will like to see?
Sir, in antenatal history, sir, I would want to find out, like he said, sir, about oligohydramnios. Sir, what is the okay, sir, on the scans? Yes, sir, on the scans, and I would want to see the sir anteroposterior diameter of the pelvis, sir. I would want to see the echogenicity of the cord, any echogenicity of the parenchyma, any parenchymal thinning if it is there on serial scanning, sir. And also, sir, the ureters and the bladder, sir, I would want to see on the scans. And yes, sir, and I would want to correlate these characteristics with serial scans in the antenatal period as well as the postnatal period if they have taken place, sir.
So what are the different inferences? What is the different school of thoughts depending upon the size of the pelvis?
Yes, sir. Sir, different schools of thought on the size of pelvis, sir. Antenatal hydronephrosis may be divided into sir, classified into on the basis of, sir, SFU grading and the UTD grading, sir. Society of Fetal Urology, sir. So on that basis, sir, four grades of hydronephrosis can be can be classified, and on the basis of UTD classification, sir, at 14 weeks and 28 weeks, I think, sir, anteroposterior diameter is taken into consideration, sir, along with cortical thickness, character of the parenchyma, sir, along with ureter and the bladder and oligohydramnios. These are the criteria which are considered in the UTD classification, sir.
Can you little elaborate?
Okay, sir. In antenatal hydronephrosis, in antenatal period, sir, there may be a low risk and a high risk stratification, sir. In that, sir, in low risk, sir, parenchymal echogenicity of in low risk patients, echogenicity of the renal parenchyma will be normal. There will be no thinning of the renal parenchyma. Corticomedullary differentiation will be maintained, and sir, ureter and the urinary bladder will be normal in character. And sir, anteroposterior diameter at the end of 14 weeks will be 7 mm, and at the end of 28 weeks will be less than 10 mm, sir. This is for low risk patients, and for high risk patients, sir, it will be opposite, sir. In antenatal period, that is. So it will be more than 7 mm and more than 10 mm at 14 and 27 weeks. At the end of 27 weeks, respectively, there will be parenchymal thinning, there will be parenchymal hyperechogenicity, and corticomedullary differentiation will be gradually reduced, and ureters may also be dilated in a high risk patient in antenatal period, sir.
Just you want to add anything?
Sir, then that was a UTD classification. The SFU classification goes like grade 0, which is no hydronephrosis and the parenchyma is normal. The grade 1 will be in which there is a slight splitting of the sinus, but the parenchyma is normal. In grade 1, that is. Grade 2, there is a dilation of the pelvis and 1 or 2 calyces with the parenchyma normal. Grade 3 is when the dilatation involves all the calyces and the pelvis, gross dilatation, but the parenchyma is still normal. And grade 4, dilated pelvis, calyces, and the parenchyma is thinned out. Also, there is another classification in which we describe the hydronephrosis as mild, moderate, and severe based on the diameter of the anteroposterior diameter of the pelvis. Where at second trimester, less than 7 mm is mild, 7 to 10 is moderate, and more than 10 mm is severe. Whereas for third trimester, it is less than 10 mm mild, 10 to 15 is moderate, and more than 10 mm hydronephrosis.
Okay. So after birth, when you will do sonography and when you will do creatinine?
So after birth, we'll do the sonography after 48 hours. Both creatinine as a sonography. Creatinine we'll do after 48 hours because initial 48 hours is a reflection of the maternal value. So therefore, we do it after 48 hours. And USG also after 48 hours because initial 24 to 48 hours is oligoria. So that will be fallacious. So therefore, we do it after 48 hours.
Fine. Okay.
So, Ojas,
Yes, sir.
what are the prognostic indicators in antenatal period?
So prognostic indicators would be first is the AP diameter, then the parenchymal thickness, and then if suppose urine is as in if
Our
like the urine parameter
antenatal
of the
scan, what are the prognostic indicators?
so AP diameter and the renal parenchymal thickness and the oligohydramnios, sir, and the degree of oligohydramnios.
How oligohydramnios will decide that it is a prognostic indicator?
So we calculate the amniotic fluid index based on the amniotic fluid index.
So gestational age less than 24 weeks.
Okay.
Oligohydramnios, which will end up into the poor urine production, and there is a delayed or non-development of the lung, and echogenic kidney on ultrasound. These are 3 prognostic indicators. After 48 hours, first day to 48 hours, there is oliguria, and second day to 10th day, that is polyuria.
Yes, sir.
So you have to avoid oliguria as well as polyuria.
Okay.
So postnatal USG is either after 2 weeks or repeat after 4 to 6 weeks.
Okay.
So ultrasound should be after 2 days, that is 48 hours, or after 4 to 6 weeks, because in first 48 hours there is oliguria, and from second day to 10th day there is polyuria.
Yes.
Okay. As far as SFU you told, there is a renal pelvic dilatation 1, major calaceal 2, minor calaceal 3, parenchymal thinning 4.
Yes.
So you should make it simplified.
Okay.
And antenatal, another classification as per the trimester, you have told right. Correct.
Yes, sir.
Okay.
Okay, now, Paras, go ahead. Next, what?
So next, I would like
another thing, antenatal scan doesn't differentiate obstruction caused by obstruction, that is PUJ and multicystic dysplastic kidney, PUJ and VUR, and PUJ and transient hydronephrosis. So these things cannot be differentiated on antenatal hydronephrosis and antenatal ultrasonography.
Yes, sir.
Okay.
Okay. So what are the investigations now? You were asking about investigation.
So first, I would like to do after the examination is
No, before
we have
that,
done the
can you just tell
examination, I
me?
would like to first do an ultrasonography of the abdomen plus chest.
Okay, Ojas, before going to investigation, can you just tell me what are the differential diagnoses in this case? In this case, 1.5-year-old boy with a mass or the swelling. And
So,
after this general examination, what are the differential diagnoses that is coming in your mind?
First, I would keep as large hydronephrosis, secondary to either PUJ obstruction, then multicystic dysplastic kidney, sir, any loin mass. It could be any malignancy, any retroperitoneal malignancy as well. And
Loin mass matlab kya, Ojas? In this age, what are the urological malignancies? Don't tell vague anything.
So
There are some specific renal tumors.
So Wilms tumor and
Wilms tumor, either Wilms tumor or neuroblastoma.
Neuroblastoma.
दूसरा क्या रहने वाला इसमें?
Yes, sir. Wilms tumor and neuroblastoma. Yes, sir. And PUJ obstruction and multicystic dysplastic kidney.
Another is mesoblastic nephroma.
Yes, sir.
Multilocular cystic renal tumors.
Yes, sir.
Cystic nephroma, cystic nephroblastoma. These are some. There are rare diagnoses, but these things. So you can tell that renal tumors can be one of the differential diagnoses in this, and I will put in down the line. Initially, I will put it as a PUJ obstruction because most common cause of lump in the pediatric age group, as well as most common cause of hydronephrosis, antenatally diagnosed as well as postnatal diagnosis is PUJ. The first diagnosis is PUJ.
Yes, sir.
Another is any obstruction causing hydronephrosis.
UBJ obstruction.
Any obstruction.
Yes,
urethral wall, urethral stricture, then obstruction below infravesical
primary
obstruction.
obstructive megaureter, ureterocele,
Ectopic ureter, ureterocele, any obstruction causing the hydronephrosis. And down the line, I will consider also cystic masses, which causing the cystic renal tumors and cystic masses. That's all.
Yes.
Okay, fine. So Paras, show him the investigation.
So Manjunath is lifting hand, miracles.
Yeah, Manjunath, you want to answer something? Manjunath, you can just write down in a chat box.
Okay, we will go ahead.
Okay. Paras.
So the patient was admitted and investigation was done. The hemoglobin levels were 12. Total leukocyte count was 7,000. Serum creatinine was 0.22. On urine routine microscopy, WBC cells were 1 to 2 per high power field. RBCs were nil. This is the USG film of the patient.
Okay, Ojas,
Yes, sir.
Quick.
Yes, sir. So, this is ultrasonography at the abdomen plus pelvis. In the initial films, starting from the left, you can see that the liver is normal. Going on to the further films, you can see that the right kidney appears normal.
1 minute. 1 minute.
Yes,
1
sir.
minute. Where is the pelvis?
In the right kidney.
No. Where is the? You are saying na ultrasonography, abdomen and pelvis.
No, that's okay. Sorry, sorry. Yes, sir. Abdomen. Ultrasound of abdomen and kidney region. That's it. You cannot see the pelvis. Yes, sir. Okay. Only in the the last film we can see the I think the opposite side kidney, and in the first film we can see the liver. The liver appears normal, and in the further films you can see the right kidney appears normal. However, the cortex appears normal. The CME differentiation is maintained. Moving on to the further films, the left kidney we can see there is gross dilatation of the renal pelvis along with all the calyces, with cortical thickness being reduced, and yes, sir, there is no any other any shadow cannot be seen. And cortical thickness is reduced. The whole dilatation of all the calyces and the pelvis. The pelvis appears mainly intrarenal pelvis. Yes, sir.
Intrarenal.
Renal, sir, it is.
Some part I can see the
See the upper and lower pole and see whether it is extrarenal or not.
Actually, it's
Sorry,
extrarenal. Yeah. The parenchyma
if it is
is there. Yes,
intrarenal, you will see the dilatal calyx.
Yes,
All
sir.
the calyces will be, means you can really appreciate it. Here you are not able to appreciate.
Yes, sir. It's extrarenal. Yes, sir.
Okay.
The cortex is thinned out.
So now next, what do you want to know?
Anything on right side?
Sir, right side you can see that the calyces are dilated.
Anything on right side, huh?
Calyces look dilated. There is some mild dilatation of the calyces, but the pelvis but they are not communicating with the main pelvis though. Actually, multiple small.
एक picture में कैसे
No, sir. I would like to see the further images. This is a static scan, so I would like to ask the sonologist about the further images, because this is a static scan. I would like to confirm with the sonologist whether on dynamic imaging what was the exact findings. On this image, I can't comment, sir. I would like the sonologist discuss with the sonologist what there are other images and dynamic film is available. Dynamic thing is available.
Yeah. So this is a one good answer. All you can say is, sir, I like to see the report.
Yes,
because
sir.
this is the static film.
Yes.
Fine. Okay. So now, Paras, anything is there in the sonography? Just show him the report and go ahead.
So this is the sonography report. So left kidney is enlarged in size and show moderate hydronephrotic changes. Cortical thickness is well maintained. Renal pelvis and calyceal system is dilated. Renal pelvis is extrarenal in position and is dilated. A narrowing is seen in the left pelvic ureteric junction. Left ureter is not dilated. No evidence of renal or ureteric calculi.
Okay. Abhishek, this is us.
Yes, sir.
Now next, what you want to do?
So, sir, on the basis of these findings, sir, first off, I will explain the findings to the patient, and then I will explain the need for a functional imaging in the form of a diuretic renogram, and proceed with the diuretic renogram of this patient, sir.
Why not CT scan?
Sir, CT scanning, sir,
you
low
do
dose
CT
CT,
scan.
low dose CT protocol can be done, sir, but sir, otherwise the CT scanning is ill advised in children, sir, in infants, sir, infants and units.
Fine.
Because of radiation hazard, yes, sir.
Yes. So all of you should remember this, that it is not indicated. Unless and until you have got some doubt and you want to find out some other pathology. Otherwise, we don't do it. Okay. So
Right,
what
sir.
are the which scan you will like to ask for?
Sir, in the functional imaging, sir, either a DTP or an EC scan or a MAG3 scan can be done, sir. Both have their pros and cons, sir. DTPA is cheaper, sir, whereas EC scan is more sensitive, sir, more accurate and sensitive, sir. So, yes, sir. Basically, for a baseline record, sir, I would want to do a renogram, sir. So,
Okay.
and to confirm the diagnosis of the obstruction, sir, I would want to do a renogram.
Which
Okay.
renogram?
Sir.
So what is the purpose of doing the renogram in this patient?
Sir, first of all, baseline function, sir, for documentation of baseline function, so that follow-up is more proper in the post-op period, and to confirm the diagnosis of PUJ obstruction, sir.
So the level of obstruction, site of obstruction, differential renal function, glomerular filtration rate.
Yes.
So function and obstruction.
Right, sir.
So which is better?
DTPS.
DTPA should be better, sir.
Yes. To us, if you want to, whenever you want to assess the glomerular filtration, DTPA is better.
Yes,
When you want to
Yes, sir.
assess the differential renal function, which is better?
For assessing the differential renal function, EC or MAC3 will be better, sir.
Relative function, all the scan are equally good for assessing the relative function.
Okay, sir.
But if you want to quantify the GFR, DTP is better. To assess the
Okay.
morphology, DMS is better.
Yes.
So MAC3 scan work by how it works?
Sir, MAC3 works by tubular secretion, sir, as opposed to DTPA, which is by glomerular filtration.
So the percentage is 95 on both sides. Glomerular
Yes, sir.
filtration 95 for DTPA, MAC3 95 for tubular secretion. Yaad
Yes,
rakhne ke
sir.
liye 95.
Yes.
And EC MAC3, sir, extraction fraction is more than that of DTPA, so it is more accurate, sir.
Correct. So here what you want to do?
Function and obstruction, sir, I want to document as a baseline study.
Yes. So which scan?
Sir,
So DTPA would be okay, sir.
Okay. If someone tells EC, is it good answer or bad answer?
it is more expensive. Nice, it should be okay. So it's more expensive actually.
But EC and DTP are equally good for assessing the whatever you want to assess in this patient.
Okay.
Okay. किया है क्या स्कैन फिर?
Para show.
$60 seconds.
Para show all.
This is type 2. The split function is 5/19.
Yes, Abhishek,
Yes, sir.
would you like to comment?
Yes, sir. Sir, so in these scans, sir, sir, it is an posterior-anterior, sir, nuclear scan, and sir, in the previous image, sir, it is showing. Dr. Paras, can we go back to the previous image, please? Yes, sir. So in this, sir, in the images, it can be seen, sir, both the perfusion and the uptake. First of all, there is no Foley's catheter, sir, down below. So That is one thing. And sir, there is a good uptake and perfusion of both the kidneys, sir. And sir, in the subsequent images, sir, there is delayed drain. Sir, there is first of all tracer retention on the left side, and there is somewhat delayed drainage on the right side also, sir. And that probably may be attributed to the absence of Foley's. And other than that, there is prominent tracer retention at the on the left kidney, sir. And the drained off tracer can be seen in the collected in the bladder. Next image, please, Dr. Paras.
Yes, sir.
Right, sir. So the above findings can be corroborated in the next set of images also. And in the graph, sir, it is, sir, the right kidney, which is the graph of the right kidney, which is green. Sir, it shows, sir, uptake is good. Perfusion is also good, but sir, the drainage is normal, sir, but it is little, sir, on the drainage is little slower side, sir, probably because of absence of Foley's. Whereas on the left side, sir, there is a prominent retention of the uptake, which is not being drained at all, confirming the diagnosis of left-sided PUJO obstruction, sir, and maybe a partial obstruction on the right side, sir. Other than that, sir, on the numerical values, sir, the split function is 42.9% on the left side, 57.1 on the right side. Sir, time to maximum is 30.5 minutes on the left side, which is more than the normal limit, and 6.002 on the right side, which is okay, sir. So, sir, this also confirms the diagnosis of a left PUJ obstruction, sir.
Fine. Okay.
So they are not given any Lasix.
They are not given diuretics. They are not given
Diuretic is not given,
So,
sir.
do you feel it is necessary to give it in this patient?
Sir, it is. It
Yes, sir.
should be
It's
given.
a large
sir, yes, sir.
looks like a large hydronephrotic kidney, so there will be urinary stasis. So diuretic should be given in this patient, sir.
Yes.
Which protocol at what time it should be given?
Sir, either F0 or F minus 20, sir.
So why how it works if it is given as F minus 20 or F minus 15?
Onset of action of furosemide is onset in 1 or 2 minutes, but the peak action is 15 minutes. So in such a system in which there is the gross dilatation of the pelvis, there is stasis. So to strain the system and to know the actual function at the peak of the furosemide action, that is at 15 minutes, at the time when the radiopharmaceutical is given, that time we have to assess whether the function normalizes or whether it is still obstructed. So that's why we give it 20 minutes before, because the peak of action is after 20 minutes.
Sir, it is actually such that grossly dilated pelvis is one of the reasons for a false positive reading on a renal scan. So sir, F minus 15 protocol is justified such that the peak action of Lasix takes place in 15 minutes. So by the time the tracer is introduced into the system, sir, the kidney is in maximum stress, and such false positives which occur because of the accumulation of tracer in the hydronephrotic pelvis are bypassed. So that is the
usually the PUJ obstruction is intrinsic obstruction, so volume dependent. So whenever we give a diuretic, it causes increase in the volume, and that can help to strain the system and if suppose see whether it is going to be this thing. So it is mainly volume dependent drainage.
In simple, you are challenging the system with the load.
Yes.
Yes, sir. Yes, sir.
In equivocal cases, or a covered obstruction, by giving the Lasix prior, it will increase the load and that obstruction will seen clearly.
Yes, sir.
If you give prior to if you use a minus protocol.
Yes, sir.
So in cases which are equivocal, gross hydronephrosis, gross hydropelvis, minus protocol is usually used. Routinely used protocol is 0 protocol.
F0.
And you just told that there is intrinsic obstruction. So why only intrinsic?
So it can be both. So usually it is intrinsic obstruction. In where it is a volume dependent drainage. In extrinsic it is pressure dependent drainage.
So intrinsic and extrinsic, both obstruction can be possible.
Yes, sir.
So what are the extrinsic obstructions?
Extrinsic obstruction could be a abnormal lower polar vessel. Could be any band or any kink at any band or any kink at the level of the PUJ, or yes, sir. Mainly that lower polar vessel, apparent lower polar vessel, and any band at the level of the PUJ.
So intrinsic obstruction means what?
So intrinsic obstruction is usually it could be a peristaltic segment at the level of PUJ, or that is a usual cause. A peristaltic segment because of either decreased neurons over there, or mainly, sir. It's actually a peristaltic segment. It's an up, not neurons, decrease. It's an up peristaltic segment.
So which muscles are defective, longitudinal or circular?
Sir, longitudinal.
Abhishek?
I think circular or defective, sir.
Circular.
Circular. Okay, sir.
So these are the causes. Then we will go ahead.
Okay. So now next what, Abhishek?
Sir, I'd like to confirm with the report, sir, of this, and then okay.
Next what?
Yes, sir. Sir, so I would, sir, explain the findings of the scans to the patient, sir, and the need for treatment. Yes, sir, and the need for
Patient is
treatment.
1.5 years old.
No, sir, means the patient's parents, sir. And sir, the need for treatment in this patient. Also, sir, the fact that this is a DTPA scan, and sir, the affected side, left side, the GFR may be fallacious, sir. So in the immediate post-op period, the GFR may also drop, sir. That would also I would like to explain. And other than that, the need for treatment in this patient, sir, what will be the consequences of not getting a treatment? What are the consequences of delaying the treatment? Whatever options the patient has for a treatment, and what option of treatment I am comfortable with in the form of reconstructive surgery, and then on the basis of patient's choice, I would want to go ahead, sir.
So it's just what you want to do.
So I just want to ask one thing, sir. Should we ask for a diuretic as well to the nuclear medicine department, or we should ask for a diuretic, there's a diuretic to be administered in this patient, sir?
So if you seen a picture of ultrasound prior sending to the renogram, then that picture is there is a huge dilatation on the particular site with gross extra hydropelvis and extrarenal pelvis. So it is better to write a DTP scan with a 15 or minus 20 minute protocol. अपन खुद ही लिख देना, क्यों डबल करना है फिर? एक ही वोकल रिपोर्ट आया तो फिर डबल करना पड़ेगा. So better you should write prior.
No, the only thing is sometimes some cases they don't do this because first of all it is a very tense hydronephrotic kidney, and is just a child 1.5 years old. If you give diuretic, there are chances that he may have access formation, pain, so sometimes deterioration of the function. So that is why in some cases they don't do diuretic scans.
I
asked the person who is doing DTPA scans. So this was the answer given.
Okay. But usually they will calculate the dose as per the age and they will.
Yes. No, but only thing is this is too tense, and she said if you do more, if you give Lasix,
agreed.
It will exaggerate exacerbate the pain and all. So that is why it was not done. Fine.
So Abhishek, what is your aim in this patient of treatment?
Sir, my first and foremost goal of treatment is to preserve the renal function of that side, sir. And the second is prevent the progress of the disease on that side. And third is the reconstruction of the reconstruction of the deformed segment. So these are the three goals of my treatment in this patient.
Okay, Dr. Pankaj Maheshwari, you have been quiet. Can you just give some input?
सर है क्या लेकिन है
Dr. Anil, you want to say anything? Okay, fine. So now next what? Ojas, what you are going to offer?
As Dr. Abhishek discussed, that the relatives would be explained that this is a case of PUJO obstruction, that the kidney function on the left hand side is decreased, that this will need a treatment. Treatment, as we mentioned, that the aims of the treatment are as follows. The relatives will be explained that the chances of improvement of the renal function are only 40%. However, by offering a surgery, a reconstructive surgery, the chances of further progression of the disease can be prevented definitely. So I will offer the relatives and dismembered Anderson-Hein pyeloplasty, sir.
Why?
Why
not other method?
So in this has a redundant, is a large, huge pelvis. So it will require excision of the redundant part and then reconstruction, sir.
So why are you saying offer? Why don't you say that you will suggest?
Suggest, okay.
You are now urologist, huh? You should suggest. And
Okay,
secondly, you have to discuss the options of treatment. You just mentioned pyeloplasty. Won't you discuss options? What are the options?
Any other options than pyeloplasty?
No,
because in this patient, in spite of discussing the treatment option, this is the only option. No?
So this patient, this would be the best option, sir.
It is the best option or it is the only option?
It is the only option, sir, in this patient.
The way of doing a pyeloplasty may be n number of ways, but pyeloplasty is basically required.
Correct. That is what I
meant. Because this patient is clinically symptomatic. Patient is clinically symptomatic. Patient had clinically palpable lump. Patient had renogram-wise deterioration of renal function. Renogram-wise there is obstruction. So you have to relieve the obstruction.
So pyeloplasty is correct, but how options of treatment? That means how you'll do the pyeloplasty. That is what I was asking. There is no other option but pyeloplasty. But how? Laparoscopic, open, robotic.
And the ways of doing the pyeloplasty in pediatric age group, you have to describe what are the ways.
So open pyeloplasty you will be offering for the patient.
So you want to do open pyeloplasty. Other ways of doing the pyeloplasty in this age group?
So laparoscopic, or if a center is available at a tertiary care center, other minimally invasive in the form of robotic assistance.
Yes, so open surgery, transabdominal pyeloplasty, retroperitoneal pyeloplasty, open pyeloplasty, then laparoscopy. It is a transperitoneal laparoscopic, retroperitoneal laparoscopic, then transperitoneal robotic, retroperitoneal robotic.
Yes, sir.
Then retroperitoneal open pyeloplasty and transabdominal also open pyeloplasty. So conventionally done and routinely also done pyeloplasty in open method is just subcostal incision, transverse incision, and it is a retroperitoneal pyeloplasty. Total retroperitoneal.
When examiner asks you this question, the way Gite sir has explained all the options, you should say, sir, all these options of treatment are available, which I will discuss with the patient. However, I am well versed with open pyeloplasty. I will offer open pyeloplasty because I am good at that. That is an acceptable answer.
So, as suppose I am a father of that child, I am asking, is that function is going to improve?
So I will explain the relative that the chances of improvement of the function in this age group is around 40%. Also, this current reading is maybe fallacious
How
because
many
of the
percent?
large 40%.
At the age of 1.5 year, how many percent there is improvement?
So 30 to 40%.
So when should be the pyeloplasty done ideally?
So at 6 months to 1 year.
So 6 months is by which person? Is it a 6 month or is it a 3 month? If you know, then you tell. You don't know, then don't tell anything.
I don't know. So, but the chances of complete improvement is 100% improvement is not guaranteed. 30 or 40% chances that it will improve. Also, this current reading might be fallacious that in the further.
How do you think that paprithin cortex hydronephrotic kidney is going to improve the function at the age of 1.5 year? Ideally, as per the Ransley, the pyeloplasty should be done at 3 months, and as per the Dowley, it is at the end of 1 year.
Okay.
So दोनों जो recorded timing given है वो तो 1 साल है.
Okay.
Only within that period, if you operate, there is a 40% improvement chance.
Okay.
So which person will improve? Some people will improve, some people will get deteriorated. So in this patient, the amount of background activity counted in doing the DTP, while doing the DTP, it is showing the higher function. When you treat that particular patient, post-operatively, the percentage will go down.
Go down.
That is one thing that you have to tell prior to the patient's parent. Another thing is the hydronephrosis. Once there is hydronephrosis, it will not go. It will reduce, but it will not go.
Yes, sir.
तो 15-20 दिन के बाद में या 6 महीने के बाद में पेशेंट का फादर आता है, साहब अभी भी डॉक्टर बोल रहा है कि किडनी पे सूजन है.
That has to be explained. The hydronephrosis.
वो भी चीज पहले बताना है कि सूजन थोड़ी बहुत तो भी रहेगी.
Yes, sir.
तो पूरा जीरो नहीं होंगे. और फंक्शन कम होने का भी चांस है क्योंकि ऐसा ज्यादा काउंट हो जाता है. ये भी एक्सप्लेन कर दे.
Yes, sir.
Okay, so now what is the last, we'll not go much in detail. What is the principle of Anderson and Hines? Dismembered pyeloplasty. Give me the
diamond shape or elliptical shaped anastomosis, mucosa to mucosa, watertight, tension free, dependent drainage.
And
excision of the redundant part.
Yeah. Fine. Okay. Gite sir, you want to ask something or we just quickly go? One more thing. I wanted to know whether you like to do RGP or you will not like to do RGP.
So we would like to do an RGP.
Ojas, you are saying?
Yes, sir.
Okay. Abhishek?
Sir, RGP has its pros and cons, sir. The pros of RGP are...
No,
sir,
you tell me, when this patient comes to you, whether you like to do RGP or you will not like to do RGP, or whether it is mandatory, it is required or it is not required, it is indicated or it is contraindicated. These 3 questions you tell me.
Right, sir. In first question, sir, in this patient, I would want to do an RGP, sir. I want to get a roadmap to my surgery, sir. So I'd want to do an RGP. Second thing, sir.
Why you want to do RGP in this patient?
Sir, the RGP will give me an anatomical layout of the dilated pelvis with relation to the surrounding structures, sir. And this will help me to decide, sir, where to place my incision and, sir, what part to resect and how to go about it, sir. Secondly, sir, whether or not RGP, RGP, the pros in this case, I would want to do in this case, sir. There are 2 schools of thought otherwise. Some people do not want to do an RGP because, sir, it, according to them, sir, it may cause a lower tract and lower ureteric injury, sir, which may cause stricture, sir, which may cripple the patient for life, sir. So for these reasons, sir, some people don't want to do an RGP. And sir, thirdly, sir, RGP is not contraindicated in this case per se, sir. But yes, sir, it is as per surgeon to surgeon preference.
In this patient, in this patient, you have one ultrasonography which will give anatomy of the kidney. Okay.
Right.
So, so if you want to assess the ureter in full length, because here you are not going for a CT scan or IV.
Yes, sir.
If in adult, if you have done a CT scan, then you may have asked for CT urography and full length
Yes,
ureter
sir.
assessment can be done. Here you have not done anything for anatomy of ureter. Associated 1 or 2% chances of lower ureteric walls or stricture is always there. It is less, incidence is less, but it is there. One thing. Another thing is, if you want to place the digestate from above, so sometimes the digestate may not go. If you want to do a pyeloplasty on stent, until and otherwise you are too expert, and if you want to do a stentless pyeloplasty, then it's good. But so that's why if you tell RGP in this patient in exam, RGP can be defended very well.
Yes, sir.
That is what I was telling you, that sometimes this mass, this swelling was so big that you may not be able to see the ureter on ultrasonography. Okay. So
Yes.
as you said very rightly, we must rule out that, whether any ureteric anomaly is there or whether in a lower tract. So that is one thing. Fine. So we have done RGP. So you can justify.
Another important thing is how you have assessed the length of the PUJO narrowing if you have not done the RGP.
Yes, sir.
Because you don't have a drainage picture, you don't have picture of ureter, you have only sonography. So if suppose intraoperatively there is a 5 centimeter narrowing, which is behind that dilated hydropelvis, then you may end up into the surprise.
Yes.
If you want to do sonography, then sonography with Doppler probe also you have to do, because to rule out the additional accessory vessels. That also you
Yes,
have
sir,
not done,
crossing
because in
vessels.
CT that is indirectly detected in CT.
Fine.
Yes.
So you understand that how you
Yes.
can defend your RGP,
Okay,
right?
sir. Yes.
Okay. Fine.
Anyone want to do MCUG in this patient before going for surgery?
Yes.
Yes, sir.
In other words, what is the percentage of anomalies, associated anomalies?
So VUR with PUJ and PUJ with VUR, one part चाहिए, वो percentage याद चाहिए, मतलब चाहिए.
Right, sir.
So 10%. Associated VUR in PUJ is 10%, and associated PUJ in VUR is near about 18%, 9 to 18%.
Right, sir.
Okay. Fine. So shall we go for the different scenarios?
Yes, sir.
So quickly, Paras will just tell you the short history. Okay. You just enumerate all the investigations you need then in that patient, and then we will ask you the management.
Yes, sir.
Anyone else is there who wants to answer? Anyone has raised hand? Paras, can you just find out?
Yes, sir. No, sir. No.
Abhishek? No one?
Yes.
Everyone is afraid? Okay, no
But
problem.
sir, this is the place they can answer, sir. In the exam, they don't have any chance to do the mistakes.
Correct. But see, look at the Abhishek, and they are becoming so fluent, but still, sometimes they are also making mistakes. So if you keep on answering, I think you become more confident.
At least they are bold enough to answer the questions.
They are bold enough. Yeah. Their thinking is like that of consultant. That is very good. Fine. Okay. Paras, go ahead.
So the second scenario, this is a case of a 25-year-old gentleman presented to us with a chief complaint of on and off left flank pain since 3 years.
Your
So-
screen is not changed, Paras.
Yes, sir.
You have not changed the
Okay,
screen.
one minute. Hello.
Yeah, go ahead.
So this is a case of a 25-year-old gentleman presented with a chief complaint of on and off left flank pain since 3 years.
Okay, fine. No, go ahead with the history. Paras, we don't want to.
So the history
Important
was
history.
given by patient himself and seemed to be reliable. According to him, he was asymptomatic 3 years back when he started having left flank pain sudden in onset, colicky in nature, associated with nausea and vomiting, referred from loin to groin and was relieved by medication. Patient had multiple such episodes since 3 years for which he was on alternative therapy. Patient had increased frequency of such episodes since last 1 month. Last episode being 7 days back, associated with painful complete hematuria with no passage of clots and was partially relieved by medication. There is also history of increased frequency of urine in day and night since 1 week.
Okay. So Abhishek, this is a history. Okay. Yeah.
Yes, sir.
Just finish.
Yeah, so there is no history of fever, nausea, vomiting, burning maturation, no history of urethral instrumentation or surgery in past. There is no history of bleeding or disorder, anticoagulation, therapy or blood transfusion. No history of lethargia or trauma. No history of facial puffiness, pedal edema, breathlessness, jaundice, headache or backache.
Can
Okay,
we go
so
to the
this is-
history of presenting illness, please, Dr. Paras? Yeah.
So basically, he has got a left loin pain. Along with
Yes,
that,
sir.
he has got a
3 years.
frequency of micturition. Okay, and
Yes, sir.
hematuria.
Hematuria
is-
one.
Yeah. So he's at 25 years old. So what is your differential diagnosis?
Sir, one first differential diagnosis I can give is of stone disease, sir.
Yeah.
Second DD I can give of sir any infection of a renal cyst leading to these complaints, sir, with pain with hematuria, sir. Third can be, sir, rarely enough, sir, upper tract malignancy, sir. And but pain does not support my diagnosis in that case, sir. Otherwise, sir, PUJ obstruction can also be a differential diagnosis, sir.
What about neurogenic bladder or reflux?
Sir, he's complaining of left loin pain, sir, left flank pain since 3
Yeah. So
years.
reflux will give rise to all these three things.
Hematuria, sir, I cannot explain, sir.
Infection.
Okay.
Burning
But
micturition.
painful complete hematuria it is, sir.
No, there is one differential diagnosis.
Yes, sir.
Fine. Okay. So now what are the investigations you'd like to see?
So in this case, sir, investigations, apart from routine investigations, sir, including blood profile and renal function
Paras,
tests, I would-
anything is there in examination or anything, any positive?
No, sir.
No positive.
General and
Okay.
both are no.
So that is why. Let's go directly to investigations. So what are the things you want now?
So, sir, investigations, apart from routine investigations, including hemogram and renal function tests, sir, I would want to do a urine routine microscopy, urine culture sensitivity, urine cytology, and an extension of my clinical examination in the form of ultrasound of the KUB region, sir.
Okay. Paras, show him.
Yes.
Just okay.
On the urine routine microscopy, there are RBC 4 to 5 for a high power field, WBC 3 to 4 for a high power field. Culture is negative. The routine blood investigation are grossly normal. So this is the ultrasound. Abhishek, sir.
Abhishek,
Yes, I'm looking at it. Okay. Sir, these are the static ultrasound images of the KUB region, sir. The liver appears normal, sir. And the kidney, sir, kidneys are on the right kidney, sir. There appears to be dilatation of the pelvis with the dilatation of the renal pelvis, sir, with the can't make out, sir.
Right kidney appears normal.
No, not right. No, not right kidney. Sorry. Sorry, the left kidney. Yes, sir. Pelvis appears dilated, sir, and there is dilatation and clubbing of the calyces, sir.
It is on the right side or the left side?
Left side, sir.
Left side.
Yes, sir. And
Ojas, you want to comment anything? Otherwise, we'll go ahead.
So left side kidney, the pelvis is dilated. Right side, so whatever films you could see, the right side appears normal, sir. Left side.
What is that white shadow?
Yes, right kidney. There are some small there are small calculi in the upper and the middle and the lower calyx. Yeah.
I'm not sure, sir. There is no posterior acoustic shadowing, sir. So I'm not sure whether.
I'm actually not very sure with the imaging, sir. Could be
right side and lowermost film you just see.
What is there anything in that ureter?
Dilated ureter, sir. Dilated ureter on the right side also, sir.
Okay.
Right side ureter.
Paras, just show them the sonography
report.
Yeah.
Left kidney measures about 11.8 into 5.2 centimeter. Both the kidneys are normal in size and ecotexture. Moderate left hydronephrosis is noted due to 12 mm calculus at PUJ. Multiple 4 to 5 mm non-obstructed left renal calculi are also seen. Larger ones measuring 12 millimeter and 10 millimeter at mid-pole. Urinary bladder is distended and normal. Rest all things are normal.
So next what?
Yes, sir. Triple phase contrast CT scan of the kidney and the urinary bladder region, sir. Kidney, ureter, and bladder region, sir. I would want to do in this patient, sir. Serum creatinine is normal, so sir, yes, sir. I would want to proceed with the triple phase CT scan, sir.
Why?
Sir, I want to first of all assess. Yes, sir. So first of all, I want to assess the anatomical landmarks, sir. Then I want to see the drainage. I would want to, sir, the orientation of the calculi and the with respect to the pelvis, sir. And of course, the drainage and the ureter and the bladder anatomy I want to find out, sir. So that is why I want to do a contrast and CT scan with the drainage films, CT urogram.
So after seeing the sonography, what is your diagnosis?
Sir, on the basis of ultrasound, sir, this appears to be a left-sided PUJ obstruction.
How you have decided?
Sir, there is moderate.
It is a PUJ with stone, or it is only stone? How you have decided?
Sir, probably only because of stone, sir. The hydronephrosis may be only because of basically like a secondary PUJ obstruction because of the large stone, sir.
Why there are multiple calyceal stones?
Probably because of urinary stasis, sir. There are multiple calyceal stones.
So is it possible to differentiate obstruction due to stone or obstruction due to PUJ when there is a impacted stone at PUJ?
I'm not sure about this, sir.
Sir, on a USG, it is not classically able to distinguish whether it is because of the stone or whether it is a primary obstruction. Because, however, certain findings are there which could favor a PUJ obstruction, which would be that evidence of that will not be on a sonography though. It will be on a different imaging, like Like classically, there is a stone due to a PUJO obstruction. Those will be a smooth rounded stone, and there will be evidence of multiple other calculi in the other calyces. And whereas
Understand the question. Sir is saying there is an impacted stone at the PUJ, beta. Sir is not saying differences between calculi due to PUJ and otherwise calculi.
on the
What
UH sheet
you are
is not
saying is
possible.
that there is a PU junction obstruction, then there is secondary calculi. That we all know. Sir is saying when there is an impacted stone at the PUJ, is it possible to differentiate between a PUJ and a
No,
stone?
sir. No, sir.
So then your answer should be simple that, sir, I'll get rid of the stone, I'll explain the patient, and I'll perform a
Okay, sir.
diuretic study to understand whether there is a drainage problem or not.
Exactly.
Okay, sir.
Okay, show the CT scan.
पंकज सर आज काफी ये है bro.
शांत है. Show more. Paras. Okay. Just tell me the diagnosis. Ojas. Show the final film. That colored IVP. Yeah. Okay, fine. The first film, upper. Yeah, that left one. Can you just comment? Abhishek,
Yes, sir.
where is the
Sir, on the-
stones? Where are the stones? Arey Paras, don't move. Just show me that last 4 films.
Last 4.
Yeah. Abhishek, just see the upper right film. Where are the stones?
yes.
Paras, you are Jagan
Okay, sir. Yes, sir. Sir, on the basis of these films, sir, on the left side, sir, there are large middle and lower calyceal stones on the left side, sir. And sir, on the previous films also, sir, I could make out some amount of cortical thinning on the left side and hydronephrosis, of course, sir. This much I could make out. And can we see the?
So see, we don't want to go into too much of detail. We want to discuss more cases. So what is your
Right, so-
diagnosis? Go fast. What is your diagnosis?
So this is probably an
Paras,
impacted
show the
stone.
last film, please. That color, just see it. In these 4 films, can you see the upper right one? There are stones which are at the periphery. They are not in the center, correct?
Yes, sir. Yes.
And in
sir.
the first film, can you see the ureter, which is normal, and there is a dilatation of the pelvis, which is
Dilatation
extrarenal,
of the pelvis.
and the dilated all the calyces.
Yes, sir.
Okay, so what is your diagnosis?
Sir, so left-sided PUJ obstruction, sir,
And with
secondary calculi in the lower and the middle calyces on the left
so
side.
why you are saying they are secondary? Give reasons.
Sir, so multiple calculi, sir. There are multiple calculi, and sir, that this pain he's been having since the last 3 years, sir. So that is why correlating these 2 findings, sir, I think this is secondary stone, sir.
Yeah, and
So
then move on.
Okay, right, sir.
And they are smooth. Okay,
Yes, sir. That's
Smooth calculation. Yes, sir, smooth calculation.
fine. Okay, so next, what you want to do?
so. So
Next
in
what?
this. So next in this case, I want to do a functional imaging in the form of a renogram for a baseline study.
Fine. Sure.
Only for a
Paras,
baseline study in this case, sir.
yes, Paras, show them.
Okay, so in the CT report, there were 3 large calculi in the left kidney with moderate hydronephrosis with extrarenal pelvis. So this
DTPS
is the
scan.
DTPA.
Right, sir.
Fine. Don't go much in detail. What is your diagnosis?
Okay. So there is tracer retention on the left side, sir, up to the pelvis region. Otherwise, sir, the right side is normal, sir. So this appears to be a left-sided PUJ obstruction, sir.
With
So, Abhishek, in olden days, at the time of probably सर के टाइम पे ऐसा एक डिक्टम था कि यूरेटर दिख गया मतलब ऑब्स्ट्रक्शन नहीं. Is it stands true till today also? इसमें तो यूरेटर दिखता है दोनों भी.
But sir, there may be partial obstruction, sir, because of which ureter may be visible, sir. Moreover, the obstruction may be,
Partial
sir.
obstruction ऐसा कुछ नहीं रहता. Obstruction है या नहीं?
Give scientific answer. Sir is asking
Partial-
scientific evidence
मैं
है क्या? Sir is asking you scientific evidence. In today's day and time, what is the scientific evidence?
I have no idea.
क्योंकि उस जमाने में वो सर को पूछो गौरंग सर.
yeah, हमारे
यूरेटर
yes,
दिख गया मतलब वो नहीं है ऐसा बोलते थे.
correct. But now we are not dependent on IVP or this thing, CT scan. Again, CT scan, it is a reconstruction. So you may be able to see the ureter. So now we have to depend on DTPS scan. Okay.
Yes.
Correct.
Yes.
So this is the DTPS scan. So
Right.
on CT, so what Dr. Gite is asking is that if you are given only CT scan, CT IVP or plain IVP, will you comment on the PU junction or will like to ask for other investigations? You have to say that I will
Go
like
ahead with
to do DTPS scan to confirm my diagnosis.
yes.
Based on IVP or CT scan, you will not go ahead and do the surgery.
So
Fine.
basically, sir, renogram is mandatory in all cases of PUJ obstruction, suspected
Yes.
PUJ obstruction.
Correct. So now this is a case. So what is this diagnosis? As you said, it is a PU junction obstruction with secondary stones. Now what you will do? Or just what you will do in this case? How will you go about? You will, which surgery you will do? Number one, what you will do to the obstruction? What you will do to the stone? Whether you will do both together or you will do separately?
So in this case, it looks like that there is definite PUJ obstruction with secondary stones. So we can do an open dismembered, again open dismembered Anderson pyeloplasty with removal of the stone in the same setting with a standard anastomosis.
Why not? Why not other? Why not laparoscopy? Why not robotic? You don't want to give any option?
So
just don't use in adherent words. What is by standard anastomosis?
stented, sir. Stented assist.
Stented.
Stented assist.
Stented.
Stented assist.
Standard anastomosis ये कहाँ
Stented.
से आ गया बीच में?
Stented anastomosis.
Yes,
Yes, sir.
that's true.
Yes,
so
sir.
I would be, yes, sir. So
You
I would
tell
be
me.
more comfortable with the open surgery. However, if the patient is willing for a minimally invasive surgery, then I would call a senior surgeon who would help me assist to carry out a minimally invasive
What
surgery.
will be the problem? What will be the, if you want to remove the stone at the same time sitting or you don't want to remove the stone at in the same sitting?
We would like to remove the stone in the same settings, sir. So that in that case, open would be preferable.
Why?
You have flexible, you have laser, everything you have.
So again, sir, if I am the operating surgeon, so I would be more comfortable with an open surgery for the same. However, if expertise is available, then I would call a senior surgeon to help me in the surgery.
Correct.
So now if you do laparoscopy or robotic surgery, will you be able to catch these stones and remove?
Yes, sir. Lap assisted puncture we can take, sir, remove the stones and then carry out a pyeloplasty in that laparoscopic setting, sir.
So you want to do lap assisted PCNL and you want to do lap pyeloplasty.
Yes, sir, because RIRS is going to take a long time for such a large stones with large.
But if you do RIRS, that means you have fragmenting stone. Then what are the chances that after during the same sitting, if you are breaking the stone and if you are doing the pyeloplasty, what are the chances? One, of stricture formation, stone recurrence of the stone formation and stenosis. You will like to remove the stone in toto or you want to break the stone and remove?
In toto, sir.
In toto, sir.
So which is the best option?
So lap pyeloplasty plus lap assisted puncture and removal of the stone.
So again, you will have to break it. If you do lap PCNL, any type of
So then
PCNL.
open, sir. The open
तो
is open.
पाइलोप्लास्टी में लैप्रोस्कोपिकली पेल्विस ओपन है ना,
That can also be
तो
done.
उसमें से कुछ डाल सकते हैं क्या?
डाल सकते हैं, but that forceps are not so big to hold that one of the stone. So anyway, you can give these answers, but your answer should be, I will like to remove this stone if possible without breaking. Because once you break, there are chances that infection can spread, the fragments may remain inside, okay? And then it may get stuck at the anastomotic site and you may have complications.
Right.
Okay.
So best answer in exam is open surgery.
Yeah. Suppose you want to, is there any other option? Can you do PCNL first or RIRS first, and then can you do pyeloplasty, or you want to do first pyeloplasty and then you can do RIRS or PCNL? Ojas?
Sir, I would like to live in the same setting, sir. The same
Yeah,
setting.
would you like to? I'm asking you, can you do that also?
Sir is saying, is there another option? Many people do it like that. That's why sir is asking you.
I'm not
Sir,
sure.
one option is, sir, we will do a PCNL, remove the stone, pass a stent, and sir, in follow-up, we'll see whether the hydronephrosis is whether the hydronephrosis is decreasing or not.
See,
And
the
then
practical thing is, if you do PCNL first, there are usually chances that it may get stuck, the kidney, and then the after that the surgery may be little difficult. Okay.
Yes.
Okay.
So it is better that in a virgin case, if you want to do two procedures, it is better first to do reconstructive surgery, wait for some time.
Pyeloplasty. Yeah.
Pyeloplasty, and then go ahead. Best answer is, you want to do, according to me, best is open surgery, okay, with the removal of stone in toto. That is a
right.
I will like to do that first. Otherwise, as
Have
you
you
said
seen
very rightly, you
different
can
stone
do.
removal forceps?
Yeah.
Have you all seen?
See,
Yes, sir.
open, it is very big. Okay.
Yes.
Fine. So all these things, you should know all the permutation combination.
Sir, open
Otherwise-
stone, sir, the stone removal forceps, urolithotomy forceps, and pyelolithotomy.
Yeah, so they are
All
big.
yes, sir. Those I have seen, sir. Yes.
Plus, even you can do nephrolithotomy and can remove that big stone.
Yes, sir.
So in open,
but
Calcial stone with block infundibulum hai, we have to do a nephrotomy, remove the stone.
correct. Fine. So these are
You
the
can
answers.
hold the stone and cut over that and just extract it. And then take
So, okay,
the.
Paras, what we did in this case, just tell them and we'll go ahead.
So this is the RGP film. We just put a glide wire.
Yeah. So we did. Yeah, we did the pyeloplasty.
Yes, sir.
Yeah. Show the next film.
So there's a video, sir.
Okay. Then forget about that.
Okay.
But I will tell you, we removed two stones very easily. Third stone was not coming out. We tried we tried to do a nephroscopy from the open pelvis, RIRS, everything, but it was very difficult to catch the stone and remove. So we did a as Dr. Gite suggested, we did the nephrotomy, nephrolithotomy, and removed the stone totally. Okay?
Yes, sir.
right.
Fine. Paras, next case. Just see, this is a problem. We were not able to catch the stone. Okay?
Right, sir.
Yes, sir.
Okay, Paras, can you show the next case?
Yes, sir. One minute. One minute, sir.
Yeah.
Abhishek sir, can you see the new case?
I can see the, yeah.
Yes, we can see.
This is a case of a 24-year-old gentleman student resident of Mumbai presented to our side with history of pain in right flank on and off since 3 months, fever since 3 days, nausea and vomiting since 3 days. So, history of present illness. History was given by patient himself and seemed to be reliable. According to him, he was asymptomatic 3 months back when he started having pain in the right flank region, sudden in onset, progressive, dull aching in nature, and was relieved on medication. Pain has increased since last 3 days and is associated with nausea and vomiting. Patient also complains of fever with chills since 3 days, which was relieved on medication. So there is no history of nausea, vomiting, or burning maturation in past, but there is history since 3 days. There is no history of urethral instrumentation or surgery. There is no history of bleeding disorder, anticoagulant therapy, or blood transfusion. No lithuria or trauma. No facial puffiness, pedal edema, breathlessness, jaundice, backache, or headache.
Paras, go ahead. Go ahead. Everything is negative otherwise, correct?
Yes.
Yeah.
On
So
general
next,
exam.
yeah, anything
on
is positive in general
no,
examination?
No, sir. No.
Nothing. Okay, fine. So, Abhishek.
Per abdomen examination there. On per abdomen examination,
Yeah.
inspection, there's renal angle fullness is present on right side. It's on palpation, a lump of is palpable in the right lumbar region extending to the umbilicus and right iliac fossa. It is about 20 into 15 in size, soft to firm in consistency, non-compressible or reducible, bimanually palpable, non-ballotable. Right angle renal angle tenderness is present. On percussion, there's normal resonant note over lever span, but the percussion note on the lump is dull. Genitalia and DRE is normal.
Fine. So what, Abhishek, what are the investigations? Come on,
Yes,
fast.
sir. Yes, sir.
Important
Sir,
investigations and we go ahead.
yes, sir. So this appears to be a case of pyonephrosis, sir. So I would send investigations. Concurrently, I would want to place a PCN in this patient, sir. Investigations apart from routine investigation in the form of hemogram and renal function test.
Don't commit the mistake by telling patient in initial phase. So it is just all the features are suggestive of infection in the system. It may be pyonephrosis, it may be infected hydronephrosis, it may be due to renal stone, it may be due to ureteric stone, it may be due to ureteric stricture. We don't know anything.
Right, sir.
So here, the first important investigation: CBC, urine routine, urine culture, serum creatinine, random blood sugar. One ultrasound, one X-ray QAB, otherwise one CT NCCT.
Right, sir.
So Paras, just yeah.
Yes, sir. Yes, sir.
What you are saying is right. Yes, Paras, show them.
So on urine routine microscopy, the WBC were more than 100 per high power field and RBC was 6 to 8. Culture sensitivity was negative for growth. On blood investigation, hemoglobin was 10.5, TLC was normal.
Okay, go ahead.
So the ultrasound film is not available. So the ultrasound, there is a on the right kidney, it shows a gross hydronephrosis with PUJO narrowing with floating internal echo suggestive of pyonephrosis or parathin parenchyma and paper-thin parenchyma.
And
Sir?
On the left-hand side, anything is there?
Mild increase in cortical echogenicity.
Okay, fine. So Abhishek, now next what?
Sir.
Suppose I like to admit the patient.
So there are internal echoes inside.
First, admit the patient, after an IV access, send blood and urine for culture, starting from broad spectrum IV antibiotics, hydrate him, maybe put a catheter for output charting as well as for the output charting. And then I would, after stabilizing the patient, then I would advise CT scans.
CT scan.
Creative 1.3, sir.
So what more information you will get by doing CT scan? So here problem is silent patient and having a time for investigation or something else.
So then just counsel after the patient.
Now, how much is the TLC?
6,000.
TLC is normal, sir.
Normal.
Then how much is, what are the symptoms? Is there any renal tenderness, angle
Yes, sir.
tenderness?
Yes,
There
sir.
was
Is the patient had a fever?
Yes, sir.
So patient had a fever, patient had a renal angle tenderness, then internal echoes inside the sonography
Pelvis.
in the kidney or in the pelvis.
Yes, sir.
So system is anhydronephrotic oblique pynephrotic kidney. The system is blocked and got infected.
Yes, sir.
So by doing the CT scan, is there any change in your planning right now?
No, so then first consider for drainage, sir. We will attempt degestenting or yes, sir.
So either you have to go for internal oblique external drainage.
Drainage, yes,
And
sir.
you have to defend the way you are telling in exam. If you are telling the digestion, then defend it. If you are telling the PCN, then defend it like that.
Sir, PCN I think will be preferable because, sir, can be done in emergent setting. No anesthesia required, sir. And besides, we don't have a roadmap for the distal, the ureter and the lower tract, sir. So I think PCN will be
So
appropriate in this case.
n number of benefits. You can monitor that particular renal unit output. You,
Yes, sir.
the pus can be sent for culture. In future, you can go for anatomy by doing the nephrostogram. Then if you don't want to do open pyeloplasty, then that same puncture can be used for endopylotomy. कुछ भी depend कर सकते हैं करना.
Right.
And internal echoes है तो PCN will be better than DG.
Yes.
Better drainage. That is the most important thing to start with.
जी sir. जी sir.
Yeah. So these are the all advantages in exam. If such a case comes and if the drainage is asked, you say preferably PCN.
Okay.
Fine. Okay. So now this is a CT scan. Just see. As a protocol, we have done CT scan because I want to rule out many other things which ultrasonography may not be able to show. For example, if it is a very large, whether the pus is very thick, that also you can make out. Second thing, whether there is any urinoma formation, okay, that also you can make out. Third thing is function on the opposite side and what is the status of the left kidney, that also you can make out. So the structure, yeah.
So I
Plus
think
the extension of this kidney, all these things you can make out. So you
both
can
schools
plan
of
your
thought are
surgery.
there, sir. Like both schools of thought, like Gite sir said that it may in the emergency setting it may not be required, but sometimes in private practice you have to document all these things also. So city and plus city has all these additional benefits that the ureter, the distal tract, the opposite kidney, emphysematous changes, the thickness of the pus, like sir said, all these extra factors can be ruled out. And if creatinine is high, at least one plain CT will definitely throw some light.
So whatever
Sometimes
we
even
want to tell in the exam, you have to defend that.
defend it, correct, sir. And plus sometimes some slough papilla or some slough in the ureter can be seen also.
Right. So Abhishek, what is your diagnosis?
So diagnosis in this case is right-sided pelvic junction obstruction with pyonephrosis, and gross thinning of the renal parenchyma, and also on the so there appears to be I think hydronephrosis is also there on the left side, sir. So some amount of fullness is also there on the left side, so yes, sir. And
so now next, what do you want to do?
Sir, next I would want to document the functioning of, I want to do a functional imaging, sir, in the form of DTPS scan. Yes, sir, and document the function. And on the basis of that, sir, I want to go ahead, sir, for further management.
Paras, have you done?
Yes, sir.
Show them.
So yes, sir. In this,
Right kidney, no uptake at all.
right kidney shows no uptake at all, and there is retention on the left side, sir.
So now what we'll do? Show the curve, Paras. So what is your diagnosis?
So there is
Left side non-functioning kidney secondary to PUJO obstruction with pyonephrosis.
And the right side, I mean left side or right side?
It's a right side, and with yes, right-sided. This thing, left side, sir, we can't comment. There's just there is left-sided some
Right.
right-sided PUJO obstruction with non-functioning kidney with pyonephrosis.
Yeah. The curve is showing normal on the left hand side. Paras,
yes,
what are the findings? Just read it out.
So in the dynamic cortical images, left kidney, it appeared to be average in size and normal in shape. The cortical tracer uptake appears to be normal and uniform. The intrarenal transit time is normal. On the right kidney renal fossa is replaced by a large cold photon deficient suggestive of grossly dilated pelvic calyceal system. The cortex appeared to be thinned out. Significantly reduced tracer uptake is noted in the thinned out cortex. So the GFR on the left side is 66 ml per minute. On right side, it is 12.8 ml per minute. Time to reach peak is 8 minutes in the left kidney and 0.7 in the right. T half is 9.5 in left and 0.2 in right. Split function is left kidney is 83% functional and the right kidney have a function of about 16%. So the final report suggestive of right kidney demonstrate a grossly dilated pelvic calyceal system with thinned out cortex. It demonstrated severely compromised cortical function and GFR. The drainage cannot be commented due to severely compromised GFR with increase in intrarenal transit.
Yes. So Abhishek,
yes,
what
sir.
will you offer?
So I want to I'll explain the findings to the patient, sir, and the need for treatment in this patient. I would explain that these parameters are borderline parameters, and in this patient, I would offer him, sir, a drainage, preferably by PCN, and observation for a period of time, and then reassessment for the kidney function on the right side, and then going ahead with the definitive management, sir. If the kidney function is improving, I'll go ahead with the reconstructive surgery. And if the function is deteriorating, or if it remains the same, sir, then I would go ahead with the right-sided nephrectomy, sir.
Now, if he has got a pyonephrosis, such a huge kidney, paper thin parenchyma, just because you are able to see some function on the right hand side, which may be because of hydronephrosis, you are seeing so much of global GFR. You will still
Yes,
like
sir.
to control this kidney, and
For
then
a
he will
brief
have a
period
recurrent
Abhishek.
urine tract, and there
Yes,
are
sir.
chances that this infection can go on the opposite side. What are the chances that the wrist, sees wrist stricture or pyonephrosis will not recur after the reconstructive surgery?
Differential renal function less than 15 and GFR less than 10 is ideal indication for doing the nephrectomy. Here
Yes,
there is a 16.5 and 12.5, marginally more than the whatever
borderline.
the
Yes, sir.
indications. So in the exam, it is better. I will first drain the system, and drain means anything. It can be DJ, it can be patient as per your convenience, and you have to defend that. And if you want to do just reassess the DTP, to do one more DTP, definitely this function will go down because there is a grossly hydronephrotic kidney. That 12 GFR may come to 4-5 GFR, and differential function come to the 8 to 10, and at that time I will go for nephrectomy. So it is
Yes.
just for the legal my legal protection, I will going for that particular way. Ideally, you are correct, sir. This patient needs nephrectomy only.
Right, sir.
So examiner will also happy. You are also happy.
Correct.
Yes.
So these are the different ways to answer. Okay. But
Right,
what you do practically and what you answer in exam, you have to be little diplomatic.
Right.
Huh?
Right.
Fine. So, okay. Paras, what we did?
So we took the patient today in emergency and we have done a right-sided DJ stenting.
Yeah. Okay. But there was no pus in that. Correct?
Yes.
The urine was quite clear, even though it was showing. Fine. But ideal answer, I think in this case, if you want, the best answer will be to do PCN instead of doing DJ stenting. But
हाँ
because
सर क्या है कि PCN के लिए सजेस्टिव पायोनेफ्रोसिस का सजेस्टिव क्लिनिकल फीचर्स भी है एंड अल्ट्रासाउंड में इंटरनल लिकोज है तो PCN बोला तो कोई गलत नहीं है. अगर डीजे में बोल रहे तो यू हैव टू डीजे के लिए फिर अलग अलग आंसर्स देना पड़ेंगे कि बैग नहीं रहेंगी, लीकेज नहीं होगा, स्लिप आउट नहीं होगा, तो इंटरनल ड्रेनेज रहेगा.
So when we did the thing, ureteric catheterization, we saw that the clear urine is coming. So PCN was deferred. Okay,
Yes.
fine. Paras, this is the last case?
Yes, sir.
Yeah, go ahead.
So this is a case of a 25-year-old gentleman presented to us with a right-sided loin pain since 14 days. So we further investigated these. This is the ultrasound film of the patient. Abhishek, sir.
Yes.
Abhishek, Farafat,
Yes,
all
sir.
different. See, we are giving you all different scenarios. So in exam, you know, you will be wise enough to, even if you get a combination of any case, you will be able to answer.
He's a 25-year-old male.
Female, female patient. It's a left ovary.
Female, left ovary, I can see.
Female patient. She's a
Right,
female.
sir.
There is gross hydronephrosis.
So on the sir, on the these are the static images of the ultrasound, sir. And on these images, I can see, sir, the liver appears normal. The adnexa appear normal. Spleen appears normal. Left side kidney and bladder appears normal, sir. Left-sided hydronephrosis with blunting of calyces can be seen, and dilate some part of the upper ureter also appears to be dilated, sir. The the parenchymal thickness appears to be preserved on all sides, sir. And yes, sir, the cortex also does not appear to be hyperechogenic, sir.
So just tell me what are the investigations that come in your mind. So we'll just show you.
So other than routine blood investigations, hemogram and renal function test, urine routine microscopy, urine culture sensitivity, and ultrasound, of course, has been done.
Anything in the lower pole?
Looks like
Okay, we will see the report.
Okay, first show the report. Paras.
अल्ट्रासाउंड रिपोर्ट नहीं है.
नहीं है.
सिटी बोल दो.
the lower pole vessel. City we can see
yes,
left-sided hydronephrosis secondary to PUJO obstruction, and there is a aberrant left lower polar
vessel
arising from the aorta. Lower
Yes.
polar
Okay,
vessel.
fine. Renogram किया है ना?
Yes, sir.
Show them.
This is the CT report.
Yes, just read the CT report and show them renogram.
So in the CT, the right kidney measures 9.6 into 4.6 centimeter, and the left kidney measures 10.9 into 4.2 centimeter in the sagittal plane. Both the kidney appear normal in size and shape and exhibit good prompt function without any evidence of radiodense calculi. A 0.85 centimeter size simple cortical cyst is seen near the upper pole of the right kidney without any internal septation, calcification, or solid enhancing component. Mild hydronephrosis is seen with abrupt transition at the PUJ or pelvic ureteric junction obstruction with 5.5 centimeter size enhancing wall thickness. A single right and two left renal arteries are arising. from the abdominal aorta with single renal vein on the either side draining into the IVs. So this is the DTP.
Say it properly and answer me.
Right, left.
Left side there is delayed drainage. Actually, uptake is okay on both sides. Left side there is delayed drainage.
See the
Perfusion
final
is
stage.
Right.
The right hand side lowermost. Yeah.
Right side lowermost.
Right hand side lowermost. Okay, show the next one.
Rest of GFR is more.
Just check the 24-hour image.
Yeah, so 24-hour image. Yeah, so both there is delayed drainage, but finally they both are draining. But
Show the
yeah,
report.
the report is functional. GFR left side more. 56.
Show the report, bye.
Okay. So report is
Not with you.
no sir.
There was a report. I have not given you.
No sir.
Okay, fine. So what you will like to do, Abhishek?
Yes, sir. After explaining the condition to the patient, sir, and explaining the findings of the CT angio to the patient, sir, I would offer her dismembered Anderson Hines dismembered pyeloplasty by
Question number one, whether you like to do anything or you don't want to do anything.
What is the age of the patient?
25 years old female, sir.
What is the differential function on that obstructed side you are suspecting?
Differential.
What is the GFR on that side?
Yes, sir. GFR is 56 on that side, sir.
What is the clinical presentation of that patient?
She presented with loin pain, sir. Right side loin pain.
So obstruction is on left or right?
Obstruction appears. GFR is 56 on the left side, 46 on the right side.
Both sided T half कितना है?
So T half is around. So T to half is 8.75 on the right side and 1.06 on the left side. So right side appears obstructed, sir.
कितना रहना चाहिए T half?
So T half 20 से कम रहना चाहिए,
तो कम है कि ज्यादा है फिर?
कम है सर.
ऐसा नहीं है, less than 10 is normal, 10 to 20 is equivocal, more than 20 is obstructive.
Okay.
So it is 8.75 is less than 10 na?
Yes sir.
So it is normal.
Right sir.
So GFR is normal, T half
Yes,
is
sir.
normal,
Yes sir.
age is 25 years,
Yes sir.
use is congenital anomaly, up to 25 year this much renal function is already maintaining, but patient had a
Pain.
loin pain.
On the right side, yes.
Yeah. So why patient had a loin pain?
Is it because of kidney? It is because of chondritis, or it is because of muscular pain, or what it is?
Or is it an intermittent obstruction caused by that? So it is really proved that lower polar vessel usually cause obstruction.
Or you took a guess that today pyeloplasty, so all PUJO obstruction.
No, not the pyeloplasty, sir.
See, if you go to see that CT IVP with a renogram, na, you can see there is a filling defect exactly where this lower polar artery is lying on the ureter. Just see. Can you see that?
Yes, sir.
Yes, sir.
So definitely this low polar artery is causing some sort of like an impression on this or feeling defect in this pelvic ureter, means upper ureter to some extent. But whether it is worth going inside or not, how will you suppose you in your private practice, if you get such a patient and you want to convince yourself that yes, this patient definitely requires surgery, what will you do?
Sir, so this is a 25-year-old female, sir, and sir, I would want to offer this patient surgery because, sir, at a later date.
Sir is saying you want to confirm whether the surgery will benefit or not. Understand the question.
Yes,
Is there
sir.
something you can do in the interim to understand whether the pain is because of the obstruction?
एक पुराने जमाने में करते थे वो।
Can you do something and reassess?
चला गया कि उसको बोले।
Hydronephrotic drip.
Can you do something to assess whether the pain will go away? नीचे से कुछ डाल सकते हैं क्या?
Uretary catheter डाल के सर
Uretary catheter पे पेशेंट घूमता रहेगा क्या?
नहीं सर।
Uretary catheter पे पेशेंट घूमता रहेगा बाहर लटकता हुआ?
नहीं
फिर
सर।
क्या डालोगे?
सर डिजेस्टेंटिंग करके देख सकते हैं सर।
Yeah, so then say that. Sir wants that answer.
Yes sir.
So practical thing I'm saying that if you do degestenting, the pain goes away. Then when you remove the degestant, again the pain comes. Means what? This pain is definitely because of left-sided PUJO junction.
It is a crude way of assessing, but this is sometimes practically what sir is telling. In practice, you come across such situation. What answer will you give the patient? So then patient also understands that yes, digestate has taken away the pain, so definitely pyeloplasty will help. Understand?
Right, sir. Sir, here whether we should offer her pyeloplasty on the left side also or not, sir, because of the crossing vessels, or we leave it as such, sir, because she's young right now, sir. So
symptomatic कौन सा side पे है?
Symptomatic right side, sir.
So Gite sir asked you so many questions.
Yes, sir. No, but sir,
don't do something because it is there. Is it causing any problem?
No, sir, not right now.
Then you go to do it and you injure a lower polar vessel and cause you have to do heminephrectomy. Then what will you do?
Yes, sir. Yes.
So not everything that should be done, can be done, should be done.
Right. PUJO is on left side or right side?
If the pain may be on the right hand side, but the
PUJO
is on the left hand side.
On the left side, that's what, sir. Yes, sir.
So you want to you want to operate on the PUJO side, or you don't want to operate on PUJO side?
That's what, sir. Sir, later life mein, sir, if she lands up with
later life, you want to operate, you don't want to operate. That's all.
No, sir.
That particular site is asymptomatic. That side renal function is preserved.
Function is preserved. Okay. No, sir, I will not touch that side. No, sir. No, sir, I will not touch that side. No, sir, not right now. Not right now. Not right now.
So what you will then on right side.
So how will you manage this case? What you will tell the patient? So you tell the patient, see, very simple, that please come for a regular follow-up. Go to the same ultrasonologist to do the ultrasonography scan every 3 monthly for next 1 year. If there is no increase in hydronephrosis, okay, once you can repeat DTPA renal scan to see that again there is no deterioration. So if there is no pain, if the hydronephrosis is not increasing, there is no deterioration of the renal scan, you can just do a follow-up and see, and then you can call after 1 year. If it is not,
the cause for
so if it is giving pain, or if the patient has got any symptom, or hydronephrosis is increasing, or DTPA scan is showing delayed function, then you go ahead and do the surgery.
Right.
Most important message today in these lovely cases that sir has shown is that when not to do anything also is very important. Examiner wants to know whether you want to do or you don't want to do. My professor in Holland used to tell me not doing anything is also treatment.
Right.
So that is a very, very important take-home message. Now this is the final polishing that you all are receiving, just before the exam. So keep your mind open. Just don't do because it is there. Because there's a crossing vessel doesn't mean you have to go and operate. So many crossing vessels must have lived their lives throughout without having any problems.
Right, sir.
Excellent cases, sir.
Yeah, I think we have covered almost everything. One more case was there.
Showing
That
these two renal
Paras,
arteries from the aorta, so beautiful that image is.
yeah. Only thing is Paras
Yes, sir.
could not get one more case. Hey, Paras?
No, sir.
No, no. Yeah, that was a left-sided
PUJ
renal calculus in the small boy with the right-sided PU junction obstruction. So if we get sometime, we'll show
Superb.
you. Huh?
Superb combination, sir. 4 nice cases. Very good.
So Abhishek, last question
Yes,
for
sir.
both.
Yes, sir.
There is a proved PUJ and there is a viewer. You want to treat PUJ or you want to treat viewer first? Grade 4, grade 5 viewer, and there is PUJ obstruction also.
First,
Treat.
treat
So
the
we
viewer.
want to
sir,
treat the viewer first,
Viewer
sir.
first. Viewer first.
Absolutely wrong.
No? Okay.
Why?
Both of them saw the answer in the chat box and answered.
No,
No, sir.
no, sir. No, sir. So
No,
actually,
sir. I would,
sir, yes,
sir,
we will treat
the
the PUJ
justification
obstruction
was,
first.
sir, ki,
We
sir,
will
the
treat
justification, what I was wondering was ki we would want to treat the infection first by treating the viewer and then go ahead and do a PUJ. That was
Dekho.
what I was thinking, sir.
PUJ worsens with time and viewer resolves with time. मैंने ये तो बोला नहीं ना कोई पेशेंट का.
Yes, sir.
Yes, sir.
Yes.
तो तुम रेनल फंक्शन को लॉस करना चाहते हो कि बचाना चाहते हो?
Okay, sir.
Right.
Yes.
So obstruction should be treated first.
Yes.
Fine. I think we had a good discussion today. I am happy.
Yes, sir.
Thank you very much for all of you to attend.
Thank you so much, sir.
Thank
Thank you, sir.
friends.
Yes,
Thank you,
sir.
And
Gaurang.
Thank you,
Thank you,
everyone,
Gite, sir.
I'm
Thank you.
requesting you again and again, please, other students, please volunteer and answer. It will be, for us also, it will be a great enjoyment because we know that you people are interested. Okay? Fine.
Just go back
Okay.
and finish the topics, whatever we are discussing, so that it is done. And,
हिरेन
Yes,
सर
sir.
नासिक आ रहे क्या?
yes, sir. Yes.
मिलते हैं फिर.
Yes, sir. दो सेशन में पैनलिस्ट.
जी सर.
Sure. Okay.
ठीक है,
Good
sir.
night,
Bye, sir.
everybody.
Thank you,
sir.
sir.
Good night.
Thank you, Gaurang
Good
Shah,
night.
sir. Thank you, Gite,
Thank
sir.
you, sir.
Thank you, Hiren Sodha, sir.
Thank you,
Good
Gite,
night.
sir.
Good
Thank you,
night.
Gaurang, sir. Thank you, Sudha,
Well
sir.
done,
Okay.
Abhishek.
Thank you,
Time
sir.
for
Thank you,
us.
sir.
Bye bye. Abhishek, तुम लोग motivate करो other students को. Please ask
Ah,
them.
sir.
Huh?
Ah, sir.
Okay.
Ah, sir.
Put it
Ah,
on
sir.
your personal chat and with group and just tell them. Okay.
Right. Right. Sir.
Okay. Bye. Bye. Good night.
Thank you, sir. Good night, sir.
Good
Thank you.
night.